Welcome to the deep dive. Today we're tackling a really complex area, musculoskeletal tumors. It's just such a vast range of possibilities, isn't it?
Right.
Really demands a systematic, multimodal kind of thinking.
Absolutely. And what's so key, I think, right from the get-go is weaving in those clinical factors. The patient's age, exactly where the lesion is.
Right, that initial assessment.
Yeah, it's like our first filter. It helps us start sorting things out. Is this likely primary, metastatic, or maybe even one of those don't touch lesions, which, saves the patient a whole lot of unnecessary worry and procedures.
Okay, so starting that diagnostic journey then. Plain radiography still feels like the first port of call for most, right?
Yeah.
Still the cornerstone.
Oh, definitely. It's affordable, accessible, and it does this unique thing, collapsing 3D anatomy onto a 2D image. It's great for that initial triage.
And what are the key things you're zeroing in on there?
Well, we're really looking closely at the margins. Are they sharp, maybe sclerotic, suggesting slow growth? That's your type IA. Or well-defined but no sclerosis, type IB. Or are they ill-defined, blending into the bone, like type IC?
More aggressive signs.
Exactly. And then you get into the really aggressive patterns, type 2, the moth-eaten look, or type 3, permeative, where it just filters through the bone. Plus, the periosteel reaction is huge.
Like Codman's triangle or the onion skin appearance.
Precisely. Those tell you about the speed and nature of the growth. And of course, the matrix itself, is it producing that fluffy, cloud-like osteoid, or does it have the arcs and rings of chondroid matrix? Big clues there.
Okay, so X-ray gives us that foundation. But what if we need to see the soft tissues around the bone better? Where does ultrasound fit in?
Yeah, ultrasound is interesting. It's not the primary tool for looking inside the bone, but it's fantastic for checking out any associated soft tissue mass.
Assessing vascularity, too.
Right. With good color Doppler technique, you can see flow patterns, maybe just scattered normal vessels, or sometimes those really disorganized anarchic vessels, suggesting malignancy. And crucially, it's excellent for guiding biopsies, especially for soft tissue masses. The diagnostic yield is really high, often quoted around 95%.
So efficient for getting tissue. Makes sense. Now, for the bone itself, fine details, subtle changes. CT must be critical there.
Oh, absolutely. CT is king for bony architecture. It shows cortical integrity like nothing else, picks up subtle permeation, and it's definitely superior for characterizing matrix mineralization.
Distinguishing the osteoid from chondroid you mentioned.
Exactly. That fluffy versus arc and ring pattern is much clearer on CT. Plus, it's great for biopsy guidance in bone and really useful for staging, looking for subtle lung mets and osteosarcoma, for instance, though you still want a proper chest CT sometimes.
Okay, now, MRI. This often feels like the heavyweight champ in bone tumor imaging, especially for marrow and soft tissues.
It really is indispensable. The soft tissue contrast is just phenomenal, and it's unparalleled for seeing the extent of marrow involvement. That's absolutely vital for staging and planning surgery.
Knowing exactly how far it goes.
Yeah, intramedullary extent, whether it crosses the physis, is it invading nerves or vessels nearby? MRI shows you that. We use a whole suite of sequences. T1 gives you great anatomical detail, shows marrow replacement.
And fat suppression highlights the tumor?
Right. Sequences like T2 fat sat or STR make the tumor and any associated edema really pop. Chemical shift imaging can be clever too, looking for microscopic fat, which can help differentiate some things.
But contrast.
Contrast-enhanced MRI helps assess vascularity, viability, distinguishes tumor from necrosis pretty accurately too, maybe 80% or so. And then there's DWI, diffusion-weighted imaging.
Cellularity. And maybe treatment response.
Exactly. High cellularity often restricts diffusion. It's also being used more for whole-body screening and seeing if treatment is working early on. We even have ways to optimize it around metal hardware now.
Fascinating stuff. Okay, last modality, PTCT. What unique piece does that add? Metabolic information.
Precisely. PTCT, usually with FDG, looks at metabolic activity. So FDG avidity can be very useful for systemic staging, finding distant disease, and monitoring treatment response, but, and this is a big but.
It's not just about the SUV number.
No, definitely not. You absolutely have to correlate the FDG uptake with the CT morphology. High uptake doesn't automatically mean cancer. Think giant cell tumors. They can be very hot. And some low-grade malignancies might have low uptake.
So context is everything.
Always. It's great for distant mets detection, but like I mentioned with CT for really tiny lung nodules, a dedicated diagnostic chest CT is often still the standard.
So pulling it all together then. We have all these tools, all this information. The real skill is synthesizing it, isn't it? integrating everything with the clinical picture.
That's exactly it. Our role is to build that coherent diagnostic story. It's this layered process, age, location, plain film pattern, CT details, MRI extent, PTT activity, putting all those pieces together to stratify the risk.
Guiding those crucial next steps. Observe, biopsy, plan surgery.
Right, and always working closely with the orthopedic oncology surgeons. That collaboration is fundamental, especially for complex things like limb-sparing procedures.
Yeah, our role really is central to getting the best outcome for the patient. It goes way beyond just reading the images. It's about guiding the whole process.
Couldn't agree more. It's that integrated, collaborative thinking that makes the difference. And, just as a final thought, we're seeing deep learning models now that are getting scarily good at classifying primary bone tumors on x-rays, sometimes matching fellowship-trained radiologists.
Wow.
Yeah. So how is that going to change our workflows and how we collaborate in the future? Something to think about.